Welcome to the Deep Dive, the place where we distill the sources and give you the essential knowledge fast. Today, we are wading into a complex and a really vital area, providing specialized dental care for children who have special healthcare needs, or SHCN.
It's a crucial topic.
Our mission in this deep dive is to pull out that core clinical and logistical roadmap. How do we ensure these patients get dental management that's both effective and, importantly, safe, considering their complex medical situations?
It really is essential. And maybe we should start with the basics. Like, who exactly are we talking about when we say SHCN? It's a broad term.
Yeah, good point. What's the quick definition?
The official AAPD definition is pretty comprehensive. It's basically any child with a physical, developmental, mental, sensory, behavioral, cognitive, or emotional impairment, or in any limiting condition that means they need specialized services or programs.
So a very wide umbrella then.
A very wide umbrella, yes.
And the sources really highlight that getting this care isn't straightforward. What are the main things getting in the way? The key roadblocks?
Yeah, it often boils down to three main things. First, there's significant parental anxiety. Understandable, of course, but it also means dental care gets delayed until problems are already quite severe.
Okay, that makes sense.
Second, the unfortunate reality of financial barriers. Accessing specialty clinics, specialized care, it can be expensive. And third, something the sources point out, is that many general dentists, well, they feel uncomfortable or maybe don't have the right equipment or training. And that discomfort can unfortunately mean these kids just don't get the timely care they need.
Wow. Okay, that really frames the stakes for us, doesn't it? So let's unpack this. Before we jump into specific conditions, what are the universal things, sort of foundational elements needed for any SHCN patient?
Right. The general considerations. First up, the physical environment. Facility access. It sounds basic, but it's non-negotiable.
Meaning?
Doors wide enough for wheelchairs, enough space in the office and operatory for movement, and ideally, mobile units, suction, x-rays, instrument controls, things you can bring to the patient.
Because if you can't even get them in the chair safely.
Exactly. Then nothing else matters, does it?
Makes sense. Logistics are key. So once they're physically in the space, what's the next critical step?
Detailed patient screening. This is absolutely vital. You need the accurate diagnosis, obviously, but also a deep dive into every medication they're taking.
Why every single one?
Well, think about side effects, like the anti-seizure drug phenytoin. It can cause significant gingival overgrowth that's excess gum tissue. Knowing that completely changes how you approach their preventive plan.
Ah, I see.
And you must get contact info for their primary physician or relevant specialists. This has to be coordinated care. You can't work in a silo.
Right, right. And I guess that level of detail extends to just booking the appointment, too. You mentioned timing earlier.
Oh, absolutely. First visit logistics need tailoring. The receptionist has to know about the SHCN status right when the appointment's made. We need to block out enough time, maybe more than usual.
And the time of day matters.
Definitely. For example, diabetic patients. We usually schedule them for morning visits. That way, they've had their normal meal, taken their medication, and we minimize the risk of hypoglycemia during treatment.
Okay. And what about their overall well-being on the day?
That's the emotional status piece, but also just their physical status. You have to consider it. You wouldn't, for instance, schedule a demanding dental procedure right after a child has had something taxing like renal dialysis. You have to tailor the treatment to their current state and stamina.
Okay, let's shift to prevention. Preventive dentistry, home care, fluoride sealants. Why is this even more critical for kids with complex needs? Is it just because fixing problems later is so much harder?
It's pretty much both, yeah. Prevention becomes a genuine lifeline for these kids. Getting restorative care done, especially if you need sedation or general anesthesia, it's exponentially more difficult, it's riskier, and it's often more expensive for this group. So preventing problems in the first place is paramount.
So what does a really solid preventive program look like then?
It really starts with home care, but highly individualized. We're not just telling parents to brush. We're instructing parents, caregivers, maybe even staff in residential facilities on specific techniques, starting right from infancy.
Like what kind of techniques?
Well, for a child with motor difficulties, maybe fine motor or gross motor issues, teaching the caregiver the horizontal scrub technique might be best. And adapting the tools is key.
Adapting tools.
Yeah. For instance, a cancer patient undergoing chemo might develop mucositis, really painful mouth sores. You wouldn't use a standard brush. You might suggest soft gauze or maybe one of those foam toothbrushes instead, or modifying brush handles for easier grip.
That makes sense. Adapting the basics. What about diet? That must be complex.
Diet and nutrition, yeah. That always needs input from the physician or a dietitian. It's tricky. For a child with severe cerebral palsy, swallowing might be tough, so maybe they need a pureed diet.
But wouldn't that stick to the teeth more?
Exactly. That soft diet can lead to food stagnation, increasing cavity risk. On the flip side, a diabetic child needs a restrictive diet. So you have to look closely at the type, the consistency, and importantly, the frequency of food intake. Always in consultation.
Okay. And other preventive measures. Fluoride.
Fluoride, definitely.
Yeah.
The dosage needs adjusting based on their local water supply, just like for any child.
Mm.
But one key thing, fluoride gels are often contraindicated, avoided in patients with cerebral palsy
Why is that?
because of the higher risk of them accidentally swallowing it or even aspirating it, given potential swallowing difficulties.
Got it. And I saw mention of more advanced preventive stuff too, like stainless steel crowns, not just fillings.
Yeah, exactly. Fissure sealants are pretty standard, but stainless steel crowns, SSCs, they're particularly useful for some SHCN patients.
Why specifically?
Well, think about that cerebral palsy patient on a pureed diet, high risk of decay from food stagnation. An SSC covers the whole tooth. Or consider a patient with severe bruxism, heavy teeth grinding. An SSC offers way more protection against wear than a typical filling would.
Okay, now here's where things get maybe a bit more intense. Behavior management. If a child simply cannot cooperate, maybe due to a neuromuscular issue or an intellectual disability, what happens when the usual psychological approaches don't work?
Right. This is a sensitive area. If cooperation just isn't possible, sometimes we need to consider protective stabilization. It's only used when necessary, either for diagnosis or to deliver care safely.
And the goal is always?
Safety. Purely safety. It helps control involuntary movements, protects the child, protects the staff, protects the dentist from accidental injury during the procedure. It's used for infants sometimes, those with neuromuscular disorders, or some very resistant patients.
Can you describe what that actually involves? What are these stabilization tools?
Sure, they range from simple to more involved. You have intraoral things like mouth props or bite blocks, just to help keep the mouth open safely.
Okay.
And an interesting detail from the sources, you must attach floss to these props. Just in case they slip, you need a way to retrieve them quickly.
Wow. Okay, yeah, that's a critical detail. What about controlling body movements?
For extraoral or body control, there are devices like the Papoose board, a triangular sheet, or a PD wrap. You might recognize the PD wrap. It's often used in hospital recovery rooms. It helps gently secure limbs. There are also posy straps for extremities and head stabilizers too.
And consent for this is absolutely critical, I assume.
Non-negotiable. Clear, documented consent is mandatory before using any stabilization. It has to explain exactly what type, why it's needed, and for how long.
And if stabilization isn't enough or isn't appropriate?
Then the alternatives are pharmacological approaches. That means conscious sedation or for really extensive or complex treatments where cooperation is impossible. Otherwise, general anesthesia, usually in a hospital setting.
Okay, let's pivot now to some specific conditions, starting with developmental ones. What about patients with intellectual disability? How do we tailor communication?
Right. For intellectual disability, usually defined by an IQ under 70 plus limits in adaptive functioning, the first thing is to assess the degree of disability. You often see higher rates of poor hygiene, gingivitis, maybe malocclusion, clenching, bruxism, and even trauma.
So how do you manage the appointment itself?
Communication needs to be really adapted. Keep appointments short, schedule them early in the day, be repetitive with instructions, speak slowly, use very simple terms, and a key rule, give only one instruction at a time.
One instruction, okay.
Yeah. Let them bring a favorite toy or item for comfort. Use positive reinforcement, reward them for completing steps. Patience and clarity are key.
Makes sense. Next up, Down syndrome, trisomy 21. You mentioned a paradox earlier. What's the surprise here?
Ah, yes, the paradox. It's fascinating. Most children with Down syndrome, they're often surprisingly caries-free, very few cavities.
Really?
By T, and it's a big but. They have a high GH susceptibility to rapid destructive periodontal disease, severe gum disease that can quickly destroy the bone supporting the teeth.
Why? Why the gum disease if they don't get cavities?
It seems to be a combination of factors. Specific bite problems or malocclusions are common. There might be poor circulation in the gums. Plus systemic factors, they often have cardiac defects, frequent infections, and there are likely genetic components too.
So the dental focus shifts entirely.
Absolutely. Management-wise, they're usually very cooperative patients, but you might need to work a bit slower. The absolute priority for their oral health isn't fillings. It's preventing and managing that aggressive periodontal disease.
Okay, shifting to cerebral palsy, CP. That's damage to the brain's motor centers. What are the key adaptations needed in the dental chair, especially with potential involuntary movements?
All right, managing CP requires several adjustments. First, mobility. Can they transfer from their wheelchair? If not, you might treat them right in their chair. If they can transfer, often a two-person lift is the safest way. And you need to stabilize their head throughout the procedure.
And positioning in the chair.
Positioning is crucial. Keep the chair back slightly elevated, not fully reclined. This helps minimize swallowing difficulties. You also want to avoid sudden movements, loud noises, or bright lights flashing unexpectedly. These can trigger startle reflexes.
Right.
If you use a mouth prop to help keep the jaw open, you must give them breaks. Let them relax their jaw, breathe normally. Timeouts, essentially.
And you flagged a major safety issue here too, something about aspiration.
Yes, this is critical. The cough reflex in many CP patients can be delayed or less effective. This dramatically increases the risk of them aspirating, inhaling saliva or dental materials.
So what's the precaution?
Using a rubber dam is essentially mandatory during restorative procedures. It isolates the tooth you're working on, creating a physical barrier. It's a non-negotiable safety step, and generally work efficiently to minimize how long they need to cope with the procedure.
Okay. Wrapping up this section on developmental and sensory issues. Communication is obviously vital for sensory impairments. How do we handle hearing and visual impairments?
Good question. For hearing impairment, first figure out the best way to communicate. Do they use an interpreter? Lip reading, sign language. If lip reading, make sure you face the patient, speak slowly and clearly, but don't exaggerate your mouth movements. That actually makes it harder. Visual aids can help too.
Anything else for hearing aids?
Yes. Remember the noise from dental handpieces. You'll likely need to ask them to adjust or turn off their hearing aid during that part of the procedure.
Good point. And for patients with visual impairment or blindness?
The key is constant verbal and physical reassurance. And you have to adapt the standard dental communication technique. Instead of tell, show, do, you use tell, touch, taste, smell, do.
Tell, touch, taste, smell, do.
Okay. Describe everything. The office layout, the instruments let them touch safe items. Explain the procedure step by step using sensory details. And crucially, never move the patient, even just adjusting the chair, without giving a clear verbal warning first. Build trust through communication.
Right. Oh, that makes a lot of sense. Okay, let's switch gears now to medically compromised patients where management decisions carry really significant immediate risk. Starting with hemophilia, the clotting factor deficiency. What are the absolute dental life support rules here?
Yeah, this is definitely high-stakes dental management. An interesting point is that dentists might actually be the first to suspect mild or moderate hemophilia because a child presents with unusual oral bleeding, maybe from minor cuts or during tooth eruption.
So what about planned procedures? Surgery?
If there's any chance of significant bleeding like an extraction, it absolutely must be done in a hospital setting. And it requires close coordination with their hematologist for factor replacement therapy beforehand.
And pain control afterwards. Big restrictions there too.
Huge restrictions. No aspirin, no ibuprofen or similar NSAIDs. They interfere with platelet function, which is already compromised. Acetaminophen, like Tylenol or sometimes narcotics, are the options. Also a big one. No intramuscular injections. The risk of deep muscle bleeds, hematomas, is too high.
Wait, so even a standard shot for local anesthesia is risky. What about nerve blocks, like the ones dentists give all the time?
That's probably the single most critical point for dentists. Those common nerve blocks, especially the inferior alveolar block for lower teeth or the posterior superior alveolar block for upper molars, they are generally contraindicated. Absolutely avoid them.
Why? What's the danger?
These injections go deep into vascular tissue spaces. If a bleed starts deep in there, a hematoma can form very rapidly, and in those locations, it can potentially swell and obstruct the airway. It's a life-threatening risk.
Wow, so what's the alternative for numbing?
Local infiltration anesthesia, where you inject just around the specific tooth, is generally much safer because it's more superficial and in denser tissue.
Okay, and if you do have to take a tooth out, how do you manage the bleeding risk after?
You need specific adjunctive therapy, primarily using antifibrinolytic agents. The most common one is Amicar, or tranexamic acid.
How do those help?
In hemophilia, the initial clot might form, but it's often weak, unstable. The term is friable. It breaks down too easily. Antifibrinolytic agents help stabilize that fragile clot, preventing it from dissolving prematurely. This is absolutely crucial for preventing dangerous postoperative bleeding in the mouth.
Okay, moving to another high-risk group, cancer patients undergoing therapy. The sources lay out a really strict timeline for dental intervention. Can you walk us through those 3 phases?
Yes, the timing relative to their cancer treatment is everything. Phase 1 is before therapy. Ideally, this is about 7 to 14 days before chemotherapy or radiation starts.
And the goal here is,
Eliminate infection. Any potential source of infection has to go. That means necessary extractions, treating gum disease, get the mouth as healthy as possible before the immune system is suppressed.
what about saving baby teeth, root canals?
Here's a critical point. For primary teeth, baby teeth, pulp therapy, or root canals are generally not recommended if the child is about to become immunosuppressed. The risk of that tooth flaring up with infection later, when their system is weak, is too high. Extraction is usually the safer choice.
That makes sense.
And crucially, any needed extractions must be done before radiation therapy to the jaws or before starting bisphosphonate drugs. This is to minimize the risk of osteonecrosis of the jaw, or ONJ, which is a devastating complication where the bone essentially dies.
Okay, so that's before therapy. What about during? Phase 2.
Phase 2 is during immunosuppression. This is the period of highest risk, the general rule. Postpone all elective dental care. No routine cleanings, no fillings unless absolutely necessary.
What if there's an emergency? A dental infection?
Only emergency treatment is provided, and only after a close consultation with the oncologist. They'll guide supportive care, like whether pre-treatment antibiotics or even platelet transfusions are needed to make the emergency dental procedure safe.
Got it. And phase 3, after therapy.
Phase 3 is after therapy concludes. Now the focus shifts back to long-term oral health. Maintaining hygiene, managing any long-term side effects of the cancer treatment on the mouth, like dry mouth or developmental issues with teeth. It's about rehabilitation and ongoing prevention.
Okay, really important timelines there. Finally, let's touch on quick logistical points for 2 very common conditions. Diabetes and asthma, what are the key takeaways?
Sure. For diabetes, first point, only treat patients whose diabetes is well controlled. Schedule appointments in the morning, usually short ones, after they've had their normal breakfast and taken their insulin or medication. And managing stress during the visit is important because stress itself can raise blood sugar.
Makes sense. And asthma.
For patients with asthma, have them use their bronchodilator inhaler, their reliever puffer, right before the appointment, and make sure they bring it with them into the treatment room.
Positioning matters too.
Yes, position them sitting more upright or semi-upright in the chair, not fully reclined, as that can sometimes make breathing feel more difficult. And drug contraindications. Avoid narcotics if possible, as they can sometimes trigger bronchoconstriction. Also avoid aspirin and NSAIDs, as they can precipitate an asthma attack in susceptible individuals.
Okay, so listening to all this, it really hammers home that managing SHCN patients isn't about following a single protocol, is it? It's this constant process of consultation, adaptation, individualizing everything.
Absolutely. It's about being aware of those specific oral signs, like the gingival overgrowth from gelantin and epilepsy we mentioned, but also understanding the underlying systemic risks, like that delayed cough reflex in CP, increasing aspiration risk. You're managing the whole patient, not just their teeth.
It feels like the challenge isn't just knowing about one condition, but synthesizing potentially conflicting needs. The need for a certain diet for one condition might increase the dental risk from another, for example.
Exactly. It requires constant critical thinking and collaboration.
Which brings us to a final provocative thought for you, our listener, to consider. We've talked about the high risks of severe rapid gum disease in kids with Down syndrome and the serious complexities around surgery, even injections, for kids with hemophilia. Thinking about those heightened medical risks, how does that fundamentally shift the value, the ethical weight of just routine daily home dental care for these patients? It really transforms prevention from just good advice into an absolute necessity, doesn't it? Almost a lifeline. It's the primary tool to maintain not just oral health, but systemic safety by minimizing the need for those high-risk interventions down the road. Something to really think about.